Hello, everyone. I am very enthusiastic to be able to share with you on addressing inequities in pain management. I am Dr. Larry Charleston IV. I'm professor of neurology and director of headache and facial pain division and faculty development at Department of Neurology and Ophthalmology at Michigan State University College of Human Medicine. A mouthful, but and also chief consultant of Charleston Health Neurology and Head Pain Consultants. And you know, this is really exciting, and hopefully this will be, and you go on this journey with me as we go through these objectives. So hopefully you're able to describe at the end, you're able to describe inequities in pain management related to patient, clinician, and health system factors that contribute to adverse health outcome. We want to be able to design strategies to improve pain management in clinical practice and reduce inequities in pain care. And then finally, it makes sense, and hopefully with everyone, that we want to implement these, right? Once we understand this, kind of implement this into our common practice and implement the recommended approaches for pain management based on evidence and best practices to ensure equitable treatment. Now, okay. When policymakers, publics, and lay people and people think about pain, what are the words that come to mind? Well, this is a graphic of words that come to mind, right? So, you know, quality of life, headache, back pain, depression, anxiety, migraine, surgery, neuropathic pain. I mean, fibromyalgia. I mean, stigma. These are a lot of words that come to mind when it comes to pain, and I'm happy. And what I'll do here, if you allow me to, is go through this journey with you and kind of talk about some of my experiences. As you know, I work in headache medicine, and so that headache and migraine that shows up there, that's something that I've dedicated my career to, helping people to overcome and to reach their goals. And so I'll kind of use some of that. Some of my experiences kind of as examples, as template, but when we're talking about pain, we're talking about a whole spectrum of pain. We're talking about a gamut of pain syndromes. And in fact, pain syndromes are so burdensome across the globe. And here nationally in the USA, I mean, there are millions of people worldwide that suffer from persistent pain across their lifespan. And there's over 51 million individuals in the US that experience chronic pain, and almost about a third of those, so 17 million, have high impact chronic pain that significantly affects their activities of daily living and restricts their activities of daily living. And in fact, is over 0.6 billion dollars in annual costs for persistent pain. And this actually exceeds cardiovascular disease and cancer. And the challenge is, even though millions of people worldwide suffer from this, and it's a major cause of global disability, policy, caregivers, and the general public lack adequate understanding of pain. So we're going to hopefully help you to better understand pains, better understand the inequities as we go through this journey together of addressing these disparities and inequities in pain. Now, significant inequities in pain management and outcomes has been well documented for several decades, and this is disparities across all pain types in all healthcare settings, including primary care. And despite efforts and research to progress toward equitable treatment, multiple barriers to effective pain management persist. And there's substantial intervention that's needed in order to improve the equitable pain care in the U.S. Now, I love my PCPs, primary care providers. I mean, they're so frontline. In fact, they're so frontline that nearly all PCPs regularly treat patients who have pain. The challenge is that many PCPs lack the adequate training in pain management. And remember, I said as a headache and facial pain doc and everything, I'm going to use some of my experience. So even in headache medicine, when we look at, I talked about the global disability of pain, and I'll just use migraine, for example. Out of the neurological disorders, right? I'm going to be a little nerdy with neurology, just a little bit if you bear with me. migraine is the second highest disabling disorder across the globe, right? And this was a Lancet article that was published in 2019 that looked at that, and yet and still, only 2 to 3 hours of medical school curriculum is dedicated toward that, right? I mean, this is what's been published, and so it's not a wonder why, and even just using migraine as an example or headache as an example, and headache, by the way, migraine is just one of about 300 different headache disorders that's classified by the International Headache Classification of Disorders, International Classification of Headache Disorder, and we were in our 3rd version now. And so, needless to say, that the training is really important in pain management in general, but we can even see that even in my field. I'm gonna pick on my field. How about that, right? There's a lack of licensing requirement incentives to obtain pain care education. And the Drug Enforcement, the DEA, Drug Enforcement Agency, has recently, as of I think the end of June 2023, required that non-pain specialists, non-addiction medicine specialists, and those that are not just coming out of training have an additional 8 hours of opiate training. And I'll probably talk about that and mention that a little bit later as well. But in general, there's still much more is needed. There's a lack of licensing requirement incentives for obtain pain care education, because that's just mostly opiates. But and then there's documented lack of attention to disparities in pain management in primary care. So how to improve pain management and equities in pain care? Well, education is important. I just talked about just in headache medicine. Needless to say, and I bring headache medicine, but you know, in all actuality, there's data that support from 1990 to 2017 that the number 1 cause of disability was low back pain, right? So that's not headaches, right? But that's low back pain. Number 2 was headaches, and most of those being migrainous in nature. And that was over a period of years. So education, again, potentially there's significant benefits from improved pain curricula for initial training and continued education for clinicians. During clinical encounters, we have to address, or we should or could address, the feelings of hopelessness and perceived discrimination by people who are experiencing pain. Following guidelines. Guidelines are fantastic. Guidelines are great. And there's a lot of work. I know people that work on guideline committees and things like that. There's a lot of work that goes into the guideline, but they're only as good as, you know, when we apply them, right? So we have to apply the recommended assessment and treatment strategies to manage pain. And then at a health system level, we want to implement models and policies and procedures to minimize bias and promote equity pain care. So when we're assessing pain syndromes, what's important? And I kind of alluded to this just a little bit earlier, maybe jumped the gun a little bit, but obtaining a detailed history to understand really what is the diagnosis. I just had a patient yesterday. Was referred to me for trigeminal neuralgia. I had this facial pain, trigeminal neuralgia. Turned out that we thought the working diagnosis may have been something else, right? So we can't just slap a diagnosis without understanding the criteria for that diagnosis. And that all starts with obtaining a detailed history. And that includes review of previous records. We want to differentiate between pain types. Again, there's pain types where acute or chronic or centralized or neuropathic pain. I just told you the International Classification of Headache Disorder 3rd version has approximately 300 different headache classification or diagnosis, classification for diagnosis, right? So, in fact, that's why I got in headache medicine. I mean, if we can find the right diagnosis, then we have the options. I mean, we have the best chances of helping that patient, helping that person get the best clinical outcomes, right? And treating pain is dependent upon the pathophysiology of the type of pain. And I'll get to that a little bit more, but we want to acknowledge the influences of comorbidity and psychosocial determinants of health that impact pain. This is really, really important, and we need to imbalance the objective pain assessment with subjective pain assessments, and consider using other modalities or imaging modalities. And I remember my first case in my headache fellowship. My first case, of someone who presented with like cluster headache, right? So cluster headache, and that's a trigeminal autonomic cephalagia. So let's not get bogged down with the details, but it was okay, cluster headache. But knowing that it could possibly be a secondary, cluster headache, even though we presented with those symptoms. So that was a case where we did want to get neuroimaging. Neuroimaging modalities actually demonstrated an aneurysm, which was fixed and relieved this patient's symptoms, right? I mean, and that was my first case of a cluster type or cluster-like headache. And again, talking about the diagnosis, understanding the pathophysiology, considering the use of imaging modalities in certain cases, right? Not in all cases, but in certain cases to assess pain. Now, this biopsychosocial model of pain, it's been something that has been adapted by the VA, Veterans Health Administration, and Department of Defense, DOD. And I like how this, though, because there are factors when we look at this model, right? There are factors that essentially contribute to pain, right? I mean, there can be the biological factors, like just the pain generators or the injuries. There can be the psychological factors, right? Which could be trauma or, childhood adverse events, stress, different mood, things like that. And then social factors. How do cultural factors play a role? How does the support system or spirituality, how does that play a role? All of these factors play a role in the model of pain. And when we look at that and we look at this, these from this perspective or look at this lens, now we're able to kind of individualize the care and try to appropriate a comprehensive care plan, pain care plan, right? That is individualized for that patient, right? And keeping these model plans. So we'll keep this biosocial model of pain in mind, because there's just so many different factors that contributes to pain. Now, sometimes we have patients that may not be able to communicate the way that you and I may be used to communicating with each other. And being a nerdy neurologist here, we have examples here on the screen about pain assessment tools. And I'm going to start with like patients with dementia, right? That may be unable to self-report, right? You may use a pain assessment in advanced dementia pain scale, or our pediatric populations, right? You may use Wong-Baker faces. So the point is that there are examples of pain assessment tools that helps us to understand and communicate better with patients regarding their pain and helping actually with monitoring pain as well. Now, getting to the inequities in pain management, the International Association for the Study of Pain said over a decade ago that all people have the right to access the appropriate assessments and treatment of pain by adequately trained healthcare professionals. Yet, despite the inherent rights patients have to appropriate care, professional education about pain management is inadequate. I talked about that a little bit earlier, just in this headache sphere, right? And gaps separating knowledge about effective pain and the delivery, right? I mean, sometimes how do we deliver the things that we know what to do? How do we get patients to access, right? So there are gaps that separates the knowledge, the know-how, and then the doing how, right? The doing or the delivery of the pain care. Now, one of the barriers that may be an origin to pain inequity include clinician biases, okay? And the thing about pain, sometimes you can tell pain is an invisible disease. It's an invisible disease, and it's very, very prone to and very vulnerable to provider biases. And these biases can be unconscious or conscious biases, be negative attitudes, beliefs, perceptions, misperceptions about high-risk pain groups or pain itself. And unfortunately, I mean, there's studies that show over and over that can lead to suboptimal pain care, right? And so, because these biases, and there's a study even with like racial priming and everything, and it affects treatment and even false beliefs, we were talking about in a minute, it affects treatments and or treatment recommendations, right? And so it negatively affects the care and services provided by clinicians and social service programs, administrators, and other decision makers, right? Which ultimately, what we don't want, results in inappropriate or inadequate treatment, decreased patient reporting, decreased patient trust, decreased patient adherence, negative psychological effects, decreased quality of life. So negative outcomes and poor patient experiences and outcomes. So I kind of just started alluding to this, but cultural biases, all right, exist in the medical community against people with pain. Especially those with chronic pain. So sometimes, and there's a terminology called intersectionality, right? So just having pain and chronic pain itself can be inequity, can lead to inequities. But then you combine that with cultural biases, and this term was by Crenshaw, kind of used as a legal term, but has since made it to the health literature, where now you have these other cultural biases and this kind of intersectionality. So having pain is one thing. Being African American, let's just say that, right? Being African American with pain is another thing, and this intersect. And so this can really contribute to disparities that we see in pain based on pain biases, right? There's an empathy declines among clinicians as medical training progresses, right? And that can be for a variety of reasons. You have to rush through patients, or you have to, or you're just, tired, or like we talked about, a lack of knowledge or exacerbated knowledge deficits, and not kind of knowing what's going on in, as with regards to updates in pain. And then frustration with limited effectiveness in usual treatments for chronic pain can be another factor, right? And then complex nature of pain and pain care and risks associated with treatments can actually worsen bias, right? I kind of alluded to this just a little bit earlier, but there's been documented false belief that worsen disparities in pain care. And this has not been only seen in the public, but it's also been seen with physicians in training. And so, like, for instance, a false belief. Black people have greater pain tolerance, thicker skin, fewer nerve endings, so they feel less pain than white people. Huh? Right? It's a false belief. People don't have those beliefs, right? And those beliefs leads to greater stigmatization, right? Those beliefs leads to biases and treatment recommendations, or adverse untoward treatment recommendations, or inequitable treatment recommendations. Patients are stigmatized by clinician, family members, and general public when pain persists despite treatment, or when there are few objective findings. Again, many pain syndromes are invisible diseases. We talk about this all the time in headache medicine. Migraine is an invisible disease, right? And we don't see a lot of different objective findings or imaging or something like that with, let's say, for instance, for migraine, right? I mean, it's a primary headache disorder. So we have to be careful about the stigmatization. And in fact, I want to share this real world example by Emily, and this is a patient testimony. She said, "For the past 8 years, I have lived with debilitating chronic pain as a result of Klippel-Feil syndrome, a rare spinal defect. Over the years, I have tried every possible treatment. I've had neurosurgery, I get regular injections, massages, acupuncture. I do physical therapy and yoga daily. I wear braces, I buy expensive pillows, I meditate, I eat well, I do all the things you're supposed to do. But I also need medications. For nearly a year after the pain began, I refused to take anything. I certainly had no interest in taking an opiate, but it was only after 8 months of agonizing trial and error with other drugs that we tried tramadol as a last result and found that it worked. And yet, despite taking one of the safest opiates available and taking it responsibly for a legitimate problem, I faced restrictions that made me feel more like a criminal than a patient. Once, a doctor refused to refill my tramadol prescriptions, even while acknowledging that I showed no signs of abuse. I ended up in the ER where they told me they could only treat withdrawal. It was the most horrific and dehumanizing experience of my life. Another example was the time I wanted to consult a second pain specialist about injections. Although I wasn't asking for medication, I was berated just for asking for a second opinion and left the appointment in tears. Most recently, my health insurance suddenly refused to cover tramadol. And after much back and forth, they wanted proof that I had signed an opiate contract. I had in fact signed one, but the doctor had lost his copy. It took over 3 weeks to resolve. These stories may sound like minor inconveniences, but keep in mind what it would be like to deal with this on top of debilitating pain. I have sometimes wished I had cancer instead of a spine defect, knowing I would be treated with more respect and compassion. And let's not overlook that I'm a middle-class white female with a strong support system and a background in healthcare. I cannot imagine how these restrictions are affecting people of color, or the elderly, or those from a lower socioeconomic status. So Emily's story kind of tells us about some of the high risk and gives an example, real-world example of some of the high-risk groups and conditions prone to bias and stigmatization and discrimination. And those include women experiencing pain for chronic fatigue syndrome or fibromyalgia and other conditions, people who take prescription opiates for intractable pain, children, especially infants and others who cannot communicate, older adults, especially those in long-term setting who have limited communication. We see this mode of or this theme of communication coming in for a lot of these populations. People with substance use and mental health disorders, people with sickle cell disease or pain associated with HIV infection, and I would add people of color, right? People who have been marginalized or minoritized, especially in the U.S. They're also a group that's prone to bias and stigmatization, as we talked about earlier, even with some of the false beliefs of Black individuals. So many clinicians are not adequately prepared to address cultural components of pain care. And I like to say, when we talk about cultural components, and I have a paper actually talked about cross-cultural communication. And this was published in Headache several years ago. But it kind of looked at, cultural sensitivity, cultural relevance, and I've also heard the term cultural humility. The challenge is that the education in this are not sufficient. In fact, core competencies in pain care have been underdeveloped, and a lot of times people like to say, "Oh, I'm cultural competent," but competency, it assists that a culture is a set of skills that I can just learn. Here, let me check this off the box. Let me check this off the box. But culture is different. Culture is evolving. Culture is multifactorial. And so that's really important, but we don't have a lot of training in culture, especially in pain. And practitioners may rely on ineffective procedural and pharmacological approaches, right? And these also can have significant and unintended adverse consequences, such as addiction or misuse and things like that. So we need to figure out how to bridge these gaps in pain management to promote equitable care. But first we have to understand what the gaps are, okay, right? So this is just the overview summary of some pain gaps. So contemporary evidence is not being transferred to pain management practices efficiently or effectively. Pre-licensure pain education curricula is inadequate for many clinicians. And I talked about the DEA just recently putting on the 8-hour requirement of opioid training for renewal or new licenses for a lot of clinicians. Licensure qualifications rarely require appropriate competency in pain and assessment and management. Outcome evaluations of pain education are not routinely captured and tend to focus on the knowledge rather than competence and improved patient outcomes. Voices of individuals and their families are not sufficiently considered in pain management, planning, and monitoring. And I'll pause right here just to kind of interject. Even in headache medicine, remember I'm using this as an example. We're starting to see a lot more of patient-reported outcomes when it comes to even research. And I think we actually need more, but that's my opinion. But we're still starting to see that. A lot of times these patient-reported outcomes and maybe secondary outcomes of different studies and things like that. But what's important about the patient-reported outcomes is that it does allow the voices of the individuals, right, to come more to the forefront versus, hey, your normal pain went from a 5 to a 5 out of 10 to a 1 out of 10, right? And I think this kind of gets to the individual themselves and how that pain affects their life. So, but that's a gap, right? So making sure that we hear these voices are important. The public impact, health impact, and related public population health consequences of pain are not well understood, and then people with persistent pain often lack access or are unaware of available resources and pain and treatment options. So what can we do? Well, the National Pain Strategy Report in 2022, excerpt from that said, elimination of disparities in equity in care cannot be achieved without increased access to high quality treatment, development of strategies and expectations for equitable assessment and treatment of pain, and creation of appropriate supporting programs and services for people with pain. Right, so we need a more robust and well-trained force, right? So when we have more, that likely may improve the access for patients to receive pain care, and then well-trained is that quality of well care, right? And especially among vulnerable populations, right? We need to expand the behavioral health workforce, right, to support the needs of patients with chronic pain, substance abuse, and mental health disorders. And then, as we saw earlier, with the high-risk populations, we need to improve communication, right? Whether high risk or not, we need to improve communication between the clinicians, the patients, the caregivers, and the families. And so some of the objectives or the objectives to address pain management by the National Pain Strategy, and these objectives are actually intended to improve the quality of care and reduce barriers for vulnerable, stigmatized, and underserved populations at risk of pain disparities. So these objectives include: 1, reduce bias and its impact on pain treatment by improving understanding of its effect and supporting strategies to overcome it. 2, facilitate communication among patients and health professionals. 3, improve the quality and availability of data to assess the impact of pain and under or over treatment for vulnerable populations and the cost of disparities in pain care. And then 4, improve the access to high quality pain services for vulnerable population groups. I want to just take a quick pause on even number 3, where it says under treatment or over treatment, because sometimes we see in headache medicine, which includes headache and facial pain disorders, that there can be medication overuse, or some people like the term medication overexposure, or substance-induced adaptive headache disorders, or things like that, that can be if the treatment is not adequate. And what's important about medication overuse headache, and it is argued and debated, but what's important about that is that it's one of the highest risk factors to developing chronic headache disease or chronic facial pain disease. And so that's really important. So looking at number 3, and then under treatment obviously is a risk factor as well. For chronic pain disorders. So let's bring this back to primary care a bit, okay, and talk about recommended approaches to pain management. And I love this. I love this. Why? Because here I want to start discussing individual pain care, right? Individual pain care, right? And where does it start? It starts with a diagnosis, right? We got to get the diagnosis right. I know I've said that over and over again, but maybe that's kind of the academician in me, right? So because it gives us the best chances of the best outcome, right? Looking at the psychosocial model, right, and an approach, right, which leads us to different tools that we can use to manage pain, right? I love this kind of multimodal or multidisciplinary individualized approach. And there are several different things in our pain management toolbox. And as it says here on the screen, it's not an exhaustive list or any particular order, but understanding that diagnosis. Also, I want to add understanding the patient preferences. You know, what are they doing? How are they doing? Are they trying to take care of the family? Are they trying to go to work? Or what are they trying to do? I mean, are they? I remember using myself as an example. You know, having some knee pain, and I'm a big dude. I mean, you can't tell. I mean, sitting down doing this, but I'm a big dude. But I want to be, athletic, right? Young kids. I want to run around and everything like that. And so, what I might want to do. And where my pre-morbid condition, right, I might be, strong, may be a little bit different than maybe somebody else. And so I want a plan that's going to help me to run around with my 3-year-old, right? So be athletic, even though sometimes my wife, she questions that, these days. But anyway, the point is, that we really want to individualize the approach to the patient and make it a multimodal as applicable for the patient, right? In fact, acute and chronic pain management, the individualized multimodal approach, there's some tenets. So there's medication restorative therapies, interventional procedures, behavioral health approaches, and complementary and integrative health, that's founded, essentially informed by the tenets of one, diagnosis, right? Informed by the diagnosis. And I think a close mate two is patient preferences, right? Then we talk about kind of the access, making sure that they have access to these things, and education, understanding about this, and then the risk assessment, right? When it comes to certain different therapies, and then we want to just try to make sure they don't feel stigmatized, okay, with these. But this is what some of this, using that psycho model and using these different multimodal approaches can help us with. So let's dive into them just a little bit more. Right. So there's medications for the treatment of pain. You can have medications can be non-opiates, which we see that there's a greater interest in recent years due to a lot of different challenges with current opiate epidemic. And then there's opiates themselves. In the non-opiates, you see here on the screen are kind of acetaminophen, the non-steroidal anti-inflammatories, anticonvulsants, musculoskeletal agents, and anxiolytics. And this kind of gives you some notes on some of the things that we think about with, different, what's the pain level? What are the other comorbidities, right? What are the other diagnoses associated with the pain syndrome? What are the side effects of these different medications? And then I want to add that, sometimes there are medications that directly affect the pathophysiology of the pain disorder, right? So got to go back to my old handy dandy headache medicine here, right? When we look at migraine, calcitonin gene-related peptide therapies, right? So the antagonists and monoclonal antibodies and things like that are directly targeting the pathophysiology, or some of the pathophysiology, even though migraine is complex, that we know of that. So that's a non-opioid medications that people can take, and just using that as an example, that's why we have to have the right diagnosis. So maybe there's a non-opiate medication that actually gets at the pathophysiology, and so we would consider those more disease-specific non-opioid medications. And these are a little bit non-specific. It depends on what you're using them for these that we see on the screen: acetaminophen, non-steroidal anti-inflammatories, anticonvulsants, antidepressants, musculoskeletal agents, anti-anxiety medications. They can be non. I mean, obviously, if we're treating anxiety, then that's more disease specific, right, for that. But anti-anxiety medicine would be more disease specific, but just kind of thinking of those pain diagnoses and the pathophysiology, and that kind of gives us a sense or a breadth of where we can go with some of the different pain medications that are non-opiates. Now, consideration for prescribing opiates and the CDC guidelines for prescribing opiates for pain in 2022 stated that acute, subacute, and chronic pain needs to be appropriately and effectively treated regardless of whether opiates are part of a treatment regimen. Now, the challenge is that less than 20% of U.S. clinicians licensed to prescribe controlled substances have training on how to prescribe opiates safely and effectively. And opiates are often used early in pain treatment. However, non-opiates should be used first line when clinically appropriate. There's a lot of appropriateness, or a lot of times where it is clinically appropriate to use non-opiates. And if an opiate is being considered, then recommendations of evidence-based guidelines should ensue. So considerations for prescribing opiates: we want to have effective, it's effective for moderate and severe acute pain, but the effectiveness beyond 3 months really requires more evidence. We don't have a lot of evidence for long-term opiate use. And that may be surprising to some, you know, and we need to consider initiating opiates when the patient and clinicians deem that the benefit outweighs the risk. And I don't think not just for opiates, I mean, especially for opiates, but for other modalities as well, as we'll walk through in just a moment. We always really want to look at this risk assessment. We always want to look at, hey, what's the benefit? What's the risk? We want to make sure that the benefits outweigh the risk. And if we're using an opiate, we want to start at a low dose, titrate to the lowest dose required to achieve the goals. And what should the goals be? Well, pain management, pain control. We may not be able to totally eliminate the pain. That may be unrealistic in some circumstances. It may be realistic in some circumstances, but pain control, better daily functioning, improved quality of life are the things that we want to make sure that we are at least looking to achieve when it comes to prescribing opiates. Risk assessment, I mean, if someone's on opiate, close follow-up. Pain reevaluations throughout the duration of the opiate therapy. And then when we have people, or we're prescribing opiates, we'll maintain that opiate treatment for a period no longer than what's necessary for adequate pain control. So let's move over to some of the other modalities like restorative therapies, and you know, so therapies of therapeutic exercise. So this may include physical therapists, occupational therapists, physiotherapy, other different modalities. You may require other, like either referrals or other people part of this healthcare team. But there's high quality evidence that says established superiority of movement over rest for the management of certain pain syndromes, and physical activity or movement, and improves physical function, and can also have positive effects on secondary factors that contribute to pain and disability, such as fear of movement and anxiety and things like that. There may be devices, a TENS device or a transcutaneous electrical nerve stimulation device, or other devices. We have the different devices in headache medicine, quite a few different devices over the last 5 to 10 years. Again, some of these devices work specifically on the pain fibers that are used for certain or that are indicated or in certain pathophysiology of certain diseases. And it may modulate these, right? And, and that's important, right? Again, understanding the disease, understanding the diagnosis, and where we do that, and we've been talking a lot clinically, but again, putting on my academician hat, even when research, now we know what to research or which diagnosis we're researching, and to really see, can we get that improved high quality? Can we do research to make sure that we have the evidence that support these different restorative therapies, in particular pain disorders, right? Massage therapy, cold heat and bracing, and that may be a short period of time, not to get to muscle atrophy, for different pain disorders. So water retreating, and can we use restorative therapy in the multimodal, should I say, approach? Interventional procedures. Most interventional pain physicians offer interventional therapies for acute and chronic pain conditions. As you see here, there's examples of interventional procedures here, and even as a headache specialist, and it's an increase in complexity as it goes down the list. But as I was going to say, even as headache specialist, I mean, I do peripheral nerve blocks and trigger point injections. We also have other procedures that are specific for certain headache disorders, like FDA approved unibotulinum toxin type A for prevention of chronic migraine, as an example. And so that's a procedure, but my colleagues in pain medicine may go deeper and may do different and are trained to do different procedures and everything that try to help. And they've been around for decades. And the thing is that these vary in effectiveness and invasiveness, right? So again, that patient preference and looking at the evidence and those sort of thing, and marrying, and this is why I sometimes tell patients, try to match the evidence with what those patients' goals are, right? And interventional procedures can be a modality that helps with that. Behavioral health approaches. In my opinion, and I always tell people when I'm training, I tell you kind of what the evidence shows, and I tell you what my opinion. In my opinion, these are very underutilized, right? Very underutilized. And it could be because when we talk about behavioral and someone is coming in pain and we talk about behavioral approaches, they may feel stigmatized. Oh, you're just saying it's all in my head type of thing. I mean, I don't know how many of you all work with people who living with pain disorders, and that concern is real. They want the provider to be able to listen to them and to be able to believe them. Coming from a neurological aspect of this behavioral approach, it's telling people that this is just, it could be part of their pain syndrome, or that there are pathways in the brain, right, that connects all these things together, right? And so kind of listen to the patient, right, that communication, and putting people at ease, and then telling them about the evidence, right, that these different behavioral therapies may help with, as far as improving the function and improving cognitive and emotional responses, and helping and improve quality of life. And there's several different behavioral health approaches that are available, and with varying different evidence. So behavioral therapy, cognitive behavioral therapy, ACT or acceptance and commitment therapy, mindful-based stress reduction, biofeedback, relaxation training, and again, things have varying evidence in helping people. But remember, we're doing this in a multimodal fashion to address the patient's diagnoses, and to address the patient's need, and to help them even when it comes to coping skills and things like that. And so I believe that this is a very underutilized modality in a lot of pain disorders, and I can even say especially even in headache medicine, to be even more specific, but I believe this is across the board in some of the pain syndromes. Now, one of the challenges with getting those behavioral modalities are kind of the access to psychological pain, right? Interventions, right? Limited, we talked about this earlier, limited behavioral health specialists, or limited access, or we talk about people, we didn't talk about people, but we talked about people in a high risk population, but even those in rural areas. Like, how do you get to these things if they have to drive 3 hours or 2 hours to try to get psychological evaluation or psychological therapies and things? Well, one of the ways that could be helpful to some of these particular barriers that we do see in psychological pain interventions is using technology, whether it's mobile health or telehealth, to improve the access of psychological pain interventions, and at the same time, making sure that we can bring this up in the primary care setting, making sure that we can bring, hey, there's behavioral components to pain as well, and so that my frontline PCP colleagues are aware that, hey, these are maybe this, go to this website or go to this support group or go to this resource or what have you. There are people that have been helped tremendously or have improved outcomes in their pain with utilizing these different modalities. And so kind of looking at that access to psychological pain and utilizing the technology is a way that we can do that. And then also talking about complementary and integrative health. And these some of these have more evidence than the other, and I think that more evidence is needed to kind of put some of these into evidence-based guidelines. However, there are studies that may support these different complementary and integrative health modalities. And then again, going back to making sure people have the right diagnosis, we do that. And maybe there's studies that look at people with certain pain diagnoses with certain complementary of integrative health procedure, and kind of seeing where does this really fit. But again, as I was talking about, and said specifically when we were talking about the opiates, even when it comes to these complementary and integrative health modalities, looking at the risk versus the benefits, most of these have, potential great benefits and very little risk, which might make them more attractive to patient and using in a multimodal or multidisciplinary. And you can see how this is multidisciplinary because like in my practice, I'm not doing yoga in my practice, right? And so we're gonna need someone else that's actually skilled at that and doing the right type of yoga and things that may help benefit my particular patient population with certain diagnoses. And so again, something to consider. So when we look at special populations, all right, these certain populations have unique issues that increase complexity in painful conditions and pain management, and they may need special care and special attention. Or when we see in these populations, we may have to say, aha, okay, let me make sure that we are addressing the needs of this population. Those examples may include pediatric population, older adults, patients with cancer-related pain and those receiving palliative care, women, especially those who are pregnant, patients with chronic relapsing pain conditions, patients with sickle cell disease, military or reserve members or veterans, incarcerated individuals sometimes, chronic pain, patients with chronic pain who are undergoing surgery, right? Those with chronic pain and mental health and substance use. And we already kind of talked about this, right? The minoritized and marginalized populations that have different ethnic background are also considered special populations because they're more prone to some of the disparities that we see even within pain care. And so we just need, these patients need appropriate and adequate pain care, and again, looking at that biopsychosocial model to try to individualize the care to these patients, I think would be helpful. Again, ongoing assessment of effectiveness of pain care may be multidimensional. We need to assess. So, are patients having adverse effects, from a drug, or are they having adverse effect, or is this part of their pain syndrome, or have they done some of the behavioral things? Or the point here is that this you look at the chart here, how are we doing with the patient's goals? One of the things I always come and say to patients when I first see patients, I tell them who I am, introduce myself, and tell them I don't have a magic wand, but I tell them I want to know about their experiences. Right? I tell them I want to know what are their goals for that visit and their goals for moving forward. So when we doing these, pain assessments, how are we doing in relationship to the patient's goals, right? What are the side effects, right? Are there things that could be inhibiting the patient's recovery from pain, or the patient's improvement of pain? Maybe we need to work on some, some healthiness lifestyle things, right? Maybe. Right? Maybe we need to improve some of the behavioral modalities. Okay, maybe we need to increase and titrate the medication. Maybe they're not taking it early enough. So there's a lot of different things. And the point of this slide is just to make sure that we are looking at these assessments and looking at different, sometimes instruments can help us with this, not only patient-reported outcomes, but other assessment instruments might be able to help us with these. And so education is critical to delivering effective patient-centered care, all right? This is not only public education, but patient education, provider education, and those who make the policies, right? System education, right? Legislators and policymakers. And so we really want effective patient-centered care, optimize the patient functional outcomes, have the appropriate use of pain medications and other modalities, eliminate stigma, and reduce the risk through risk-benefit assessment. So to summarize, appreciate you all on this journey. So we're coming to a close here, right? Pain is a highly prevalent condition that causes significant morbidity worldwide and is often managed in primary care settings, right? Lack of education, clinician bias, stigmatization by the general public and high-risk populations contributes to the inequities in pain care. Initiatives to seek to eliminate disparities and promote equity in pain care by increasing the access to high-quality treatment, developing strategies and expectations for equitable assessment and control, and treatment of pain, and creation of appropriate supportive program and services, and ancillary staff, and just, one thing I didn't say and kind of summarize, but even, and the family's involvement, or those loved ones' involvement, into this approach of individualizing care, especially if family is important to that patient, or there's loved ones that are very important to that patient, right? Recommended approaches to pain management includes appropriate assessment to determine the cause and type of pain. I talked about that a lot as far as making sure, number one, we have the right diagnosis, right? Kind of figuring out, the mechanism or the pathophysiology of that pain, right? And being able to individualize multimodal, multidisciplinary care for acute and chronic pain so we can address that pain once knowing the type of pain and the diagnosis of the pain. There will be a resource toolkit for addressing inequities in pain management. We'll have that available for you. And then to receive credit, there's a post-presentation survey. We really do hope that this has enhanced your knowledge of pain care, enhanced your knowledge of inequities of pain care, and that you can take this knowledge and not only help the patients that you see and the patients that we all kind of see together, but also inform the broader populations and your colleagues as well, as we help people to live better lives and improve their outcomes in pain care. So with that, I want to thank you very much for your attention, and have a wonderful, wonderful day.